your questions in person. And so it's absolutely a delight today that we have a chance to actually learn from Dr. Hugo Issa, who is actually our newest staff surgeon at the Heart Institute, also at the CHEO, and is assistant professor of surgery at the University of Ottawa. Dr. Hugo Issa graduated from medicine, Faculty of Medical Sciences at Minas Gerais in Brazil, and did the residency training into the General Hospital of the Federal Universities of Minas Gerais, and a residency at the Heart Institute, University of Sao Paulo in Brazil. And I have a number of collaborations currently going on in Brazil, and certainly Heart Institute of Sao Paulo is the the #1 institute in Brazil. And I know many actually surgeons from Brazil as well who are, I think there's a really kind of a genetic component to the skill set. This is really a privilege. And so he was the attending cardiac surgeon at Santa Casa Hospital in Belo Horizonte and in Brazil, and then subsequently he moved northward and completed a stellar series of training programs, starting with the adult cardiac surgery program at Toronto General Hospital, University of Toronto, and then the subsequent program at the BC Children's Hospital at the University of British Columbia, and then eastwards here to University of Ottawa Heart Institute in terms of a clinical fellowship, and then follow up with a further focus on robotic and minimally invasive surgery at the Cleveland Clinic. And we're delighted that he is able to actually come back to Ottawa. And his main area of research, including coronary artery surgery, valvular surgery, but particularly congenital heart surgery, where there is actually this wonderful collaboration between the Heart Institute and also CHEO. And today he will actually give us insight on some of the projects he's doing, including construction of an ebook with a video portfolio of common procedures in cardiac surgery and interventional cardiology, as well as perspectives in research adult congenital heart disease, particularly from a surgical research focus. Thank you so much for joining us.
Yeah, I think I will work fine here. Yep, thanks a lot. Thanks for the introduction. Really appreciate. And yeah, so good afternoon, everybody. First, I would like to thank you for the opportunity to be here. I was asked to give this presentation about my research and academic goals. As a new staff in this institution, this is an excellent opportunity to get to know you, and also to you get to know me a little better. I'm still trying to understand how this institution works regarding research, and I need to find collaboration for my future academic goals. So I hope to get some feedback about this presentation and to find further collaboration to make my academic goals happen. In this presentation, I will talk first about my background that Dr. Peter Liu already talked about a little bit about it. I was asked to do that. And then I will talk about my academic goals. Let's start talking about my background so you can get to know me a little better. I'm Brazilian born, as you can figure out by my accent. I grew up in a big city with a population of 4 million inhabitants called Belo Horizonte. And Belo Horizonte is the capital of the state of Minas Gerais, which corresponds to the red area in the map. I completed my medical school in Belo Horizonte, followed by a 2-year program residency in general surgery at the University Federal of Minas Gerais. Next, I moved to São Paulo, which is the biggest city in Brazil, and completed a 4-year cardiac surgery residence at the University of São Paulo. Then I went back to my hometown, Belo Horizonte, and worked 2 years as a staff cardiac surgery in a group that had a mixed practice, in which about 40% was congenital and 6% was adult heart surgery. This group also had a mixed practice regarding health care system, which about 80% was public and 20% was a private practice. Really good experience there. In North America, I completed 1 year clinical fellowship at Toronto General Hospital, of course, in cardiac surgery. 1 year clinical fellowship in congenital heart surgery at BC Children's Hospital. In Ottawa, here at the Heart Institute and CHEO, I completed 1 year clinical fellowship. And lastly, at the Cleveland Clinic in Ohio, I trained and focused on minimally invasive and robotic cardiac surgery. Research-wise, I have experience and interest in research on both adults and congenital, of course, in the field of cardiac surgery. And it's important to mention that I'm a clinician, I'm a surgeon who does research accordingly to my clinic practice. And currently, as you all know, I'm thrilled to be back in Ottawa. My family and I were very happy. And I'm working as a cardiac surgeon here and at CHEO and academically affiliated with the University of Ottawa. Now that you know me a bit better, we will begin to talk about the main subject of this presentation, which is my academic goals. My academic goals are divided into mainly two goals: research and educational goals. Let's start to talk about my research goals. So I have just arrived in a new land. There is just 1 month I've been working here, and I'm trying to understand how research works here. I'm feeling like this astronaut arriving the moon. I still have questions that need answers. I'm working on meeting people and understand the process here, mainly regarding research. Clinical-wise, I had a good experience here and a broad experience, so I already know how things work. But research-wise, I still trying to understand it better. Those are some of the papers I have published in the past, and I'm also trying to fit my research path with my clinical practice here. And I foresee excellence, and I foresee prosperous horizons. There is a field that I'm digging into that I believe there is a lot to be done regarding research. And this is research in the adult congenital heart disease population in our area, the Ottawa area, also call it the ACHD population. So Hugo, for those who don't know, they might be asking, what is this ACHD population? Who they are? Who are they? They're those who were born with a heart defect. This defect may have been diagnosed or undiagnosed. This defect may have been treated with surgery and or with a percutaneous approach and managed medically, or even this heart defect may not have been treated. These children grew and became adults with a congenital heart disease. So basically, those are the individuals, those adults who are part of the ACHD population. And here goes a bit more information about this population. Congenital heart disease is the most common birth defect in humans, affecting nearly 1% of live births. The defects may range from mild to severe. And there are a bunch of heart defects. They are out of the scopes of this presentation to go through each of them. Still, I brought this table so you could have an idea that there are many congenital heart defects which range from mild to severe in terms of clinical presentation and prognosis for these patients. And nowadays, more than 85% of the children with congenital heart disease survive adolescence and reach adulthood. Now that you understand what this population is, let's discuss why this population must receive special attention regarding research. First of all, if you get the ACHD American and European guidelines, you will note that most of its recommendations are based in low-level evidence. As in any guideline, in the beginning, they explain class of recommendation and level of evidence. This slide was taken from the ACHD American guideline. And we can note that in some, there are basically 3 levels of evidence. I'm sure most of you already know this, but I'm going to reinforce this concept. Level A, which is the strongest evidence based on good quality RCTs and high quality studies. Level B, which is a mid evidence based on moderate quality studies. And finally, level C, which is low evidence, is the weakest level of evidence that we have, and is based in limited studies and expert opinion. That being said, I took the summary of recommendations for ACHD patients with ASD, atrial septal defect. And we can note that the level of evidence is C for all its recommendation. And this, and I just took from the ASD. There are many other recommendations for many other congenital defects. They are mostly based on low level of evidence. Here goes. Recommendation for Ebstein anomaly, based on low level of evidence. Same for transposition of great arteries. Recommendation for PDA, also based on low level of evidence. Recommendation for VSD are based on low level of evidence too. That means there is a field to be developed and a lot of research to be done regarding this population of patients. Excuse me. The second reason why this is a population that should have research focus is because it's growing. The ACHD population is growing due to a growth in the overall population. This is a projection of the Canadian population within the following decades. No matter the scenario, the prediction states that the Canadian population will grow within the next years. This other graph shows the projection of world's population. It projects that our population will grow up to 10 billion and stabilize in the year of 2100. And I could not find the projection for of Ottawa's population. Still, if Ottawa's population behaves like Canada's and world's population, we could assume it will grow within the following years, as it has been happening as shown in this graph. The ACHD population is also growing due to improvement of care. Survival rates have been increasing since the 60s. This graph shows that the fellow population lives longer according to the era when the defect was repaired. This suggests that improving care in recent eras is responsible for long survival rates. And that's not just happening with the population with tetralogy of Fallot. It also happens in the population with univentricular physiology, the patient with Fontan, Glenn, and so forth. Transposition of great arteries, population with truncus arteriosus, the population with VSD and other congenital defects. The overall survival from birth to adulthood in the population with congenital heart disease is higher in most recent eras, as shown in this graph. That gets the overall population coming from birth until 18 years old. So in sum, the message that I want to give you is that the ACD population will grow and its clinical and research demands will increase as well. And finally, the ACHD population is going to need long-term care. We usually say that patients with congenital heart disease are patched, but not cured. In other words, while these children have survived and done well until reaching adulthood, they remain at lifelong risk for late problems. So these patients are gonna need operation, reoperation, procedures, many procedures. They're gonna need tests and clinical follow-up with a range of healthcare workers, including cardiology, cardiac surgery, nurse, psychologists, and many others. A percent of them are going to present with arrhythmias, valvular lesion, residual defects, heart failure, and other issues related and non-related to the heart condition. And they're going to demand better care, not just in terms of survival, but also in terms of quality of life. And of course, they're going to demand more research. I tried to dig into our ACHD population, and I could not find much. We could start a project trying to understand our population, the Ottawa and surround areas population, in terms of epidemiological aspects, prevalence and incidence of the heart defects, how the transition from childhood to adulthood has been. Then, after we understand our own population, we could bring clinical questions and look for mutual correlations with other centers. You on this first topic, and I hope to find collaboration to move this on. So let's move to the second part of this presentation. I'm gonna have a sip here, just a second. So my second academic goal involves educational videos. It started as a hobby. I used to make it and edit videos for fun, and became an essential tool in the papers I have participated in, and in conference presentations, not just for myself, but for colleagues as well. These are a few examples of videos I edit for academic purpose, and you can find most of them in the web, on the web. This was from a robotic cabbage done here in this institution for a conference presentation about Bima Havers and minimally invasive coronary surgery. This second one was for a paper about transposition of great arteries with anomalous coronaries that we published at the Journal of Thoracic and Cardiovascular Surgery. This other one was for a UFO procedure meeting presentation. And this last one was used for another publication regarding robotic mitral repair. Create an electronic book with clinical scenarios portraying cardiac surgery and interventional cardiology procedures. Like in this slide, we would have a routine clinical case, for example, a patient with acute coronary syndrome, severe coronary artery disease that requires CABG, for example. So we would make a clinical case presentation with the patient's clinical information, age, clinical presentation, risk factors for coronary artery disease. The patient's clinical exam and tests, in this case, would be a angiogram, coronary angiogram, and an echo, for example. And we would briefly comment on the indication of the procedure and its technique and outcomes. At the end of the clinical case presentation, there would be a detailed video of a CABG procedure. And of course, the video is supposed to be the most important piece of the chapter. In the following slides, you will get a broad understanding of this project, this ebook project. So this first square there, it's going to be, I already mentioned before, but it's about a book about cardiac surgery and interventional cardiology procedures. Then we're going to divide it into sections. These sections covers the main procedures done in cardiac surgery and interventional cardiology. The section would be coronary procedures, mitral procedures, aortic procedures, aortic valve procedures, aorta procedures, heart failure procedures, congenital procedures. And this is just to give an example. We could add here, for example, EP procedures as well. And then these sections will be divided into chapters. For example, the coronary section is going to be divided into coronary angiogram, PCI, on-pump CABG, off-pump CABG, minimally invasive coronary surgery, mechanical complications that require surgical intervention. The mitral section is going to be divided into mitral clip, repair, replacement, mix. The aortic section is going to be divided in TAVI, aortic valve repair, surgical AVR, mix. The aorta procedure is going to be divided into procedures in the ascending aorta, in the aortic arch, thoracoabdominal procedures, endovascular procedures. And it goes, same with heart failure, transplants, VADs, ECMO, and so on. Same with congenital, ASDs, VSDs, switches, and so on. I still need to define rules and parameters and create a template for the chapters and videos, but I have a good idea of how it's going to work. In the videos, we'll be invited to collaborate on chapters according to their expertise. And the publication venue, such as a website, as a virtual book or scientific journal, will be decided based on the resource that we're going to have available for this project. I believe this video portfolio will help to spread technical tips and tricks of the procedures to facilitate the learning curve of trainees, surgeons, and interventional cardiologists. It will facilitate the understanding of the procedures for other healthcare workers. And this video portfolio can also dissemination recognition for all the work done here in our institution and at CHEO as well. So that's the broad info I had to bring for today's presentations. Once more, thank you very much for today's audience who came in person, who are there virtually. And I'm happy to discuss and answer questions. And those are my emails. If you want to send my email, I will certainly reply it. Thanks a lot.
Well, thank you very much, merci beaucoup. That's actually really fantastic tour de force and breaking very much new areas, and the timing is actually perfect as well. And maybe I'll get Dr. Ruel to open up the Q&A session, and I'll make some comments.
Thank you.
Thanks, Peter. Thanks, Hugo. Great job.
Thank you.
Very strong communication, as we have known you to be very gifted at. So we appreciate that. Yeah, to answer your questions, many of us read The Economist a lot. It's interesting, out of all the G7 countries, Canada is the one whose population is growing the fastest. So I think it's, imitation is the ultimate flattery, right? So people want to live here, and Ottawa is very central to that. So it's good for our institute, and we have to lift up our sleeves, because we're going to have more and more work coming from all sides, and more babies and more adults with congenital heart disease. And that's a good problem to have.
We're looking forward to that.
Yeah. Now Canadians are 40 million people for the first time. So,
yep.
But anyways, I wanted to, I think this is going to be, Dr. Beauchesne and Dr. Liu, and it's going to be the time to generate questions for your research. And, I'm just thinking of one, for instance, these young adults with congenital heart disease, as you know, just picking up amongst the many issues, the endocarditis guidelines are very, very controversial, right? And they are for prosthetic valves, they are for valve disease, and it's probably different in a 72-year-old than it is in a 21-year-old who has, but all sources and conditions with abnormal flow have a much more liberal aspect to endocarditis now. And frankly, I would say, I don't know about Dr. Voisin, but we don't often see a congenital heart disease coming with fulminant endocarditis. So maybe the new liberal kind of easygoing guidelines are fine. But I'd like your take on that. Do you think, that would be something that can easily be randomized? You can't really randomize like not closing an AV canal defect. So much of that level of evidence is going to stay the way it is. But, other questions that I would invite, Luke, Peter, and others, and Quan, and who work with you to come up with those, so that things can be a higher level of evidence than what you've showed so far, to your point.
So, well, basically, my idea is try to understand the population, as I told in the presentation. I think we should have a clear diagnosis of the patient we have, the heart disease we have. It's a broad list of heart disease here. And then once we have that mapped, I think the clinical questions are going to start to come. Randomization in these population is kind of hard as well. I think for a project that we would like to randomize, we're going to need to look for other centers and gather a workforce, and to get those answers, those questions answered. So basically, that's the broad answer I have for that. You have any thoughts on that?
Yeah, well, I just want, Hugo, congratulations on your talk. It's great to have you come on board with us. And so research in congenital heart disease is really tough. As you know, the main problem is numbers. They're small. And on the cardiology side, what we've done is in the last 10 years in Canada is really kind of do like a national kind of group efforts through our professional society. I think that the endocarditis idea of MAC is great, because there's a real with Lawrence Lau and David Masika and the surgeons, there's a real kind of thing going on right now with endocarditis, care at the Heart Institute. So I think there's a lot of potential there for some work, and I think that's a great idea. But I was just curious to know what in Canada for cardiac surgery, congenital or non-congenital, is there like a research network? Like, I think there is something in the adult cardiac surgery, but is there something with congenital? There's not that many centers. There's Vancouver, Edmonton, Toronto, Montreal, Quebec City,
yeah,
Halifax.
The centers in Canada for congenital, there are few.
Yeah.
So I've just arrived, so I'm not the best one to answer this question, but from my knowledge, I know there is a center in BC, in Alberta. I think in the mid of the country there is another center in Winnipeg, of course Toronto here, and in the east part there is 2 centers as well. So I just landed like that astronaut. I'm gonna try to find collaboration, meet people, and try to work on that. I think it's to answer big clinical questions. For sure, we're gonna have to work together. Okay, and but I wanna step by step. I want to first of all understand what we have here and see what we can do with our own forces, and then move a step forward after.
I guess an initial thing you could do is just, we did that about 10 years ago, is to just get a lay of the land in Canada, choose some form of questionnaire or kind of and I thought that was very helpful for us to understand volumes and who are potential collaborators. It's not an RCT, but it's a good way to kind of, start some form of collaborative communication.
For
kind of
sure.
network.
For
I think
sure.
it'd be interesting for me to, just as a cardiologist, to know what the
Yes.
numbers are in Canada, how we
Yeah.
compare to the States.
That's the first step.
Yeah.
Correct. We got to understand what we have before we try to do something bigger. For sure. For sure. And going back, so is there any system? We already discussed this in the hall, and so forth. But is there any system we could find the prevalence and incidence of heart congenital heart defects here in Ontario, in Ottawa, in our areas? Is that something easy to do, feasible?
Well, maybe I can just follow up on these
Okay.
great discussions. Yeah. So the timing is absolutely perfect. You landed, not just on the moon, but in fact, there's a whole Starlink system. Well, Starlink is probably a bad name, but interstellar system. Yeah, just an hour before here, I was actually helping Marcus Schwartzman and Andrew and all the others actually creating, sort of the first stage of multi-institutional application. So, so the timing is so good because the congenital heart disease right now is the number one topic for the current application of networks supported by Heart and Stroke Foundation and Brain Canada. And we have actually, been working together to lobby for this. And so there will be actually 3 teams that will be going forward across Canada. And so one will be actually transitions in care. This is the one that Marcus, will be actually co-leading together with Andrew from University of Alberta. And there will be 2 others. One is actually on brain and heart involved in congenital heart disease. Of course, we have a huge program in brain and heart, and that's why we're kind of a consultant for this program. And the last one is actually early risk detection all the way from in utero, to adulthood. And that one is being led by Luke Mertens, from Hospital Sick Children. And, so we know everybody's, Canada is small and Canada is big from that point of view. And there are linked databases now actually across Canada, so this is actually a great resource to work in. So we got to get you into that network now. Okay.
That's great.
Please do. And one of the things we'll be doing, because a huge effort of our brain and heart program is actually creating secondary use of large data. And so Heart and Stroke wanted us actually to be involved with this effort with the congenital heart disease.
Great news.
So, yeah, exactly.
Please put me in.
Exactly. So you arrive at a perfect time, for those opportunities, right? So I think the key is actually having the ideas, introduce you to all the, wonderful people across Canada. The nice thing about Canada is, people work well together. So I think this is just a perfect timing. So a couple more questions. Robin Lenz, welcome, Hugo. Thank you for the presentation. What specific areas in ACHD do you think we should start? But certainly, there are areas that we already talked about.
Yeah, exactly. It's what I told. I think we should map our population. That's the first thing. And then move forward after that.
Absolutely. Yeah. So I think you can actually, and the Quan Chan, who's also very much involved in congenital heart disease clinic, together with Luke, will be wonderful in terms of doing that as well.
Yeah, great.
Yeah. And other questions, because I have a question.
Any questions about the portfolio, the video portfolio as well?
Yeah, other questions, because I want to actually, sort of, I thought your idea on the education part is fantastic. It's really, really exciting. Right?
Yeah,
so
actually,
it's kind of video.
I
course,
should
a live book.
share these the origin of this idea with Dr. Well. And he was actually the one that planted the seed, and I kind of like the idea, and hopefully it's gonna be done in a few
If I can
times.
add, World Vision's gonna support Hugo. Everyone, when they get recruited, gets a recruitment package. So part of Hugo's recruitment package, and I hope someone from CHEO is on the call, is 50-50 supporting Hugo towards enabling that platform. So it would be maybe a new head camera or something like that, so that we can diffuse the great stuff. Because there are many in cardiac surgeries, it's a bit of a craft, right? There's many centers that are known not because they publish papers or not because they have grants or they have impact, because they have nice videos on the internet. So I feel that this aspect of what we do maybe hasn't been developed enough. And there's a great, kind of professional social media, quote unquote, if you will, platform that we can tap into. And I can think of no one better than Hugo to do that.
Yeah, and Mark will be, sort of, master ceremony, for the entire video series, so it can be on BBC and CNN and all the works. Right.
Myself catching
Yeah, so I thought that was actually a wonderful idea. And maybe you can actually bring in a little bit of on the, sort of the current evidence to practice, tips, for example, for guidelines for certain areas, as you're showing the video, you can actually, bring in those practical tips in there, which people will love. Yeah,
For sure,
absolutely.
for sure.
Yeah. Oh, what a great idea. Yeah. Okay. Other questions, comments? So lots of work for you, but
Yeah,
lots
there is a lot of
exciting
work to be
things.
done, and as I told you in my presentation, I'm delighted and very happy to be here, not just professionally, but personally as well. My family and I, we love Ottawa and the surrounding area, and professionally, it's a great opportunity to work on both sides, the adult side and with the little kids, and we'll do my best job.
Yeah, so that's great, in terms of bridging, not only on the research and education side, but also on the adult and the pediatric side, which is super important. Yeah. So thank you so much. And that's a wonderful presentation. And I think, the community is all excited as you are. And so we'll keep in touch in terms of developing some of those programs.
Yeah, and put me in that program, please. Thank you.
Sir. Thank you.
Thank you.